ABC of X-ray chest Part 1, Normal Findings. Dr. Jalal Mohsin Uddin. M.B.B.S, DTCD, FCPS, Pulmonology. Assistant Professor, NIDCH, Mohakhali, Dhaka. Index. Description of a normal X-ray chest Slide 3. Correct position of the patient Slide 4. Counting of the ribs in chest X-ray. Slide 5. Detection of the right or left side of the chest. Slide 6. Zones in X-ray chest. Slide 7. Cardiac silhouette in X-ray chest Slide 8. Tracheal shadow in X-ray chest Slide 9. Dome of diaphragm in X-ray chest Slide 11. Cardiophrenic angles and costo-phrenic angles Slide 13. Mediastinum in X-ray chest Slide 14. Hialum of lung in X-ray chest Slide 15. Cardiothoracic ratio in chest X-ray Slide 16. Good quality X-ray chest Slide 18. Fissures in X-ray chest Slide 19. Possible distribution of various lobes in X-ray chest Slide 20. Bony structures in X-ray chest Slide 22. Aortopulmonary window in CXR Slide 23. Indications of doing lateral view CXR Slide 24. Landmarks of X-ray chest lateral view Slide 25. Detection of right or left lateral view CXR Slide 28. Location of fissures in right lateral view Slide 29. Distribution of lobes in right lateral view Slide 31. Location of segments in right lateral view CXR Slide -32. Differences in distribution of lobes and segments in left lung from right 1 Slide 36. Q.1 How will you describe an X-ray chest posterior anterior view? 1. Trachea is centrally placed. 2. All the zones of both lung fields are clear. 3. Both costo-phrenic and cardio-phrenic angles are clear. 4. Mediastinum is in normal position. 5. Cardiac shadow is normal in transverse diameter. 6. Position and contour of both dome of diaphragms are normal. 7. Bony thorax and soft tissues are normal. Q.2 Is the position of the patient correct? The medial end of the both clavicles lie in equidistant from the midline of the spinous process, at the level of 4th thoracic vertebra. So the patient is in proper position. NB If the distance is unequal, then it is called that there is presence of rotation. If position of the patient is not correct, there may be false impression of shifting of trachea and mediastinum. Q.3 How will you count the ribs in chest X-ray posterior anterior view? Counting ribs on ACXR is a skill that requires some practice. Radiologists typically find rib 1 and count from there. Posterior part of the ribs are placed more transversely. Look at the first X-ray, and directed laterally and outwards, follow the sky blue lines of left side of chest of third X-ray. Usually in full inspiration, 10th rib is visible. Look at the second X-ray left side of the chest. Anterior part of the ribs are placed more obliquely. Look at the first X-ray, and directed medially and inwards, follow the yellow lines of right side of chest of third X-ray. Usually in full inspiration, 6th rib is visible. Look at the second X-ray right side of the chest. Q.4 How will you detect the right or left side of the chest in X-ray chest peer view? Right or left side of the chest is detected by following ways. A. At the upper right or left angle of X-ray plate 2 marking alpha right side of the chest or alpha left side of chest is noted according to the site. Example, here L, red arrow, is indicating left side of chest. B. Right dome of diaphragm is usually higher 1 to 2.5 cm above the left dome of diaphragm. Green arrow dot. C. Fundic gas or colonic gas is usually present under the left dome of diaphragm. Sky blue arrow, in left side. D. Apex of heart and 2/3 of cardiac shadow remain in left side. Orange arrow dot. Q.5. How will you divide the zones in X-ray chest peer view? One upper zone extends from the apices to an imaginary horizontal line and passes through the lower border of second ribs anteriorly. In right side it is called right upper zone and in left side it is called left upper zone. Two middle zone extends from the horizontal line A which passes through the lower border of second ribs anteriorly to horizontal line B which passes through the lower border of fourth ribs anteriorly. And there are right and left mid zones. 3 lower zone extends from the horizontal line B which passes through the lower border of fourth rib anteriorly up to right and left domes of diaphragms C. So there are right and left lower zones. 4 Radiological division does not correlate with the anatomical lobes of the lungs. Q.6. Describe the cardiac silhouette in X-ray chest PA view. The cardiac silhouette is the outline of the cardiac shadow as seen in postero-anterior, PA, antero-posterior, AP, and lateral chest radiographs. The silhouette sign describes the loss of the normal cardiac outline, silhouette, due to any pathology that replaces normal air-filled lung tissue. From the right cardiophrenic angle, going upwards, the right border of the heart is formed by the inferior vena cava, IVC, then mainly by the right atrium, and next by the superior vena cava, SVC. The cardiac border, silhouette, is formed by the aortic arch superiorly, followed by the pulmonary conus, the left atrial appendage and finally the left ventricle, which extends downwards up to the left hemidiaphragm and also helps to form the left cardiophrenic angle. Q.7. Describe tracheal shadow in X-ray chest peer view. The tracheal lumen appears as a vertical radiolucent shadow. It is situated at the midline between right and left clavicular heads and spinous processes can be seen through the air column but trachea is slightly deviated to right at the level of aortic knuckle. In proper erect posture trachea bifurcate at the carina which usually correlate 6th thoracic vertebra. The trachea branches at the carina into the left and right main bronchi, which can be followed as they branch beyond the hilar into the lungs. Q.7. Continue. The right paratracheal stripe is a normal, 90% cases, finding on chest X-ray and represents the right tracheal wall, adjacent pleural surfaces and any mediastinal fat between them. It normally measures less than 4 mm. Appears as a stripe that extends from the level of the clavicles to the right tracheobronchial angle at the level of the azygos arch. The left paratracheal stripe is present only in 25% cases. Q.8. What do you know about dome of diaphragm in X-ray chest peer view? Diaphragm is displayed as 2 upper convexly curved lines separated by the cardiac silhouette. Each hemidiaphragm should appear as a smooth and domed contour. On both sides, the contour of the hemidiaphragm should be seen passing medially as far as the spine S. If a vertical line X is drawn from the highest point of dome of diaphragm to the line Y connecting related costo-phrenic angle and cardiophrenic angle, it will be at least more than 1.5 cm. Q.8. Continue. In inspiration, the top of the right diaphragmatic dome coincides with the anterior end of the 6th rib. The left hemidiaphragm is usually 1.5 or 2.5 cm lower from the right. The contours of the hemidiaphragms do not demarcate the bottom of the lungs. Lung markings are still visible below the diaphragm on both sides, most clearly through the stomach bubble, fundic gas. Q.9. How cardiophrenic angles and costo-phrenic angles are formed. Cardiophrenic angles. The cardiophrenic angles are the points at which the hemidiaphragms meet the heart. In healthy individuals, cardiophrenic angles should be clear. Costo-phrenic angles. The costo-phrenic angles are formed from the dome of each hemidiaphragm and the lateral chest wall. The angles should be acute angles which are sharp to a point. In a healthy individual, the costo-phrenic angles should be clearly visible on a normal CXR as a well-defined acute angle. Q.10 How will you describe mediastinum in X-ray chest peer view? In X-ray chest peer view, the position of the mediastinum can be localized by seeing the position of the trachea and cardiac shadow. These structures are all contained between the right and left lungs. The trachea is situated at the midline between right and left clavicular heads, and spinous processes can be seen through the air column, but trachea is slightly deviated to right at the level of aortic knuckle. Regarding cardiac shadow, 1/3 of the cardiac shadow remain in right side of the spine and 2/3 of cardiac shadow usually in left side of the spine. Any deviation of mediastinum indicates underlying disease condition. Q.11 Describe Hialum of lung in X-ray chest peer view. Each hilum contains major bronchi and pulmonary vessels. The left hilum is commonly higher than the right. Check the position, size and density of each hilum. Each hilar point is the angle formed where the upper and lower lobe pulmonary vessels meet. Dotted line indicate the position of hilum. They are useful points of reference to determine the position of the hilar. Note, not every normal patient has a clearly defined hilar point on both sides. Q.12 What is cardiothoracic ratio in peer chest X-ray? The cardiothoracic ratio is measured on a peer chest X-ray, and is the ratio of maximal horizontal cardiac diameter to maximal horizontal thoracic diameter. Maximal diameter of cardiac shadow is measured by following way. At first, draw a vertical line at the middle of the chest XY line. Then draw a vertical line from the most lateral point of right border of heart on the XY line, which is seen here as a line. In the same way, draw a vertical line from left heart border, which is marked here as B line. So, here maximum diameter of cardiac shadow is A plus B. Q.12 Continue. The maximum thoracic diameter is measured by measuring the maximum distance between the inner edge of ribs. Here the distance is indicated as C line. So cardiothoracic ratio will be equals second bracket open first bracket open A plus B first bracket close divide by C second bracket close multiply 100. A normal measurement is 42% to 50%. A measurement less than 42% is usually deemed to be pathologic. A measurement search results. Web results greater than 50% is usually taken to be abnormal. Q.13 How will you identify a good quality X-ray chest peer view? Good quality chest X-ray are 1. Centering. The trachea should be equidistant between the clavicular heads. 1. 2. Penetration. The spine should be just transparent through the cardiac density. 2. 3. Inspiratory effort. At full inspiratory effort, the anterior end of the right sixth rib should point midway along the right hemidiaphragm. 3. Q.14 Show the course of fissures in X-ray chest peer view. Horizontal fissure may be seen on a normal chest X-ray as a thin line running roughly horizontally along the fourth ribs towards the right hilum. Follow the green dotted line in right lung field. An oblique fissure is not usually seen in X-ray chest peer view. But the course of the fissure can be shown by drawing a line start from sixth rib at the level of mid-clavicular line, sky blue line, reach to fifth rib lateral thoracic wall, dotted red line. In both sides, the course of oblique fissures are almost same. Q.15 Show the possible distribution of various lobes in X-ray chest peer view. In previous slide the course of the fissures are seen, and lobes are distributed according to the fissure. Right middle lobe, RML, is in relation to right heart border and between transverse fissure and right oblique fissure. Right lower lobe, RLL, and left lower lobe, LLL, both of them are associated with dome of diaphragm. Q.15, continue. Right upper lobe, IUL, is above transverse fissure and medially associated with mediastinum. Left upper lobe, LUL, is above the left oblique fissure and medially associated with mediastinum. Q.16, show the bony structures in X-ray chest PA view. Bones are the densest structures visible on a normal chest X-ray. The bones visible on a chest X-ray include their clavicles, green color. The ribs, pink color. The scapulae, yellow color. The spine, violet color, and sometimes the proximal humeri, upper arms. The sternum, sky blue color, is also included on a frontal view, but it overlays other midline structures and so is obscured. Q.17, what is aortopulmonary window in X-ray chest PA view? The aortopulmonary window is a mediastinal space located between underneath the arch of the aorta and above the left pulmonary arteries. In healthy individual it contains fat. In X-ray chest PA view the shape is concave in appearance. Q.18, mention the indications of doing lateral view CXR? The indications are: it is always better to do a lateral view to localize a mass lesion which is seen on X-ray chest PA view. To clarify the exact location of lobar collapse or consolidation. To explore the location of mediastinal tumor, lateral chest view can be particularly useful in assessing the retrosternal and retrocardiac air spaces. To confirm the presence of incysted fluid in the oblique fissure, pseudotumor. Lower lungs are better assessed by lateral view as they are obscured by hemodiaphragm in PA view. Bronchus and right and left pulmonary arteries, the major components of the hilum, are much more clearly visible on the lateral than on the PA view. Q.19, what are the normal landmarks of X-ray chest lateral view? The fissures are important landmarks on a lateral CXR. The oblique fissure begins posteriorly at T4/5 level, passing through the hilum. The left, C line, is steeper and finishes 5 cm behind the costo-phrenic angle, whereas the right, B line, ends just behind the angle. The horizontal fissure, A line, runs anteriorly from the hilum, separating the right upper lobe from the middle lobe. On the left there is no horizontal fissure. Both hemodiaphragms, D, should be visible. The anterior end of the left hemodiaphragm may be lost against the heart. The diaphragms can be distinguished from each other if there is clearly gastric air under one. Vertebral bodies, V, become darker as they proceed caudally until they reach the diaphragm, because there is more soft tissue and less lung tissue at the apex, but more lung tissue and less soft tissue at the bases. Q.20, what are the other structures can be seen in lateral view? 1 left main bronchus. 2 right scapula. 3 left atrium. 4 left ventricle. 5 inferior vena cava. 6 left costo-phrenic angle. 7 right costo-phrenic angle. Q.20, continue. 8 right humerus. 9 left humerus. 10 trachea. 11 aortic arch. 12 posterior surface of arms. 13 manubrium. 14 body of sternum. 15 right ventricle. 16 gastric bubble. Q.21, how will you detect right or left lateral view CXR? If there is no written information, right/left lateral view, the radiology department usually supply left lateral view. We can identify right, R, or left, L, lateral view by seeing characteristics of right or left dome diaphragm, fissures, cardiac shadow, etc. Anteriorly the left dome is lower than right dome due to presence of heart on it, green arrow. The stomach fundus gason or colon are immediately subjacent to left dome, yellow arrow. There is no segmental obliteration in left lateral view, L, by the inferior vena cava as it often found in the right lateral, red arrow, view, R. When both major, oblique, fissures can be identified, the left, sky blue line, almost always intersects its diaphragmatic dome posterior to and more vertically than the right fissure, red line. Q.21, continue? In adults the outline of the left dome is often sharper. Anterior 1/3 of left dome is obscured by cardiac shadow, pink arrow. Right dome extends up to costo-phrenic angle, green arrow. In right lateral view our right dome is much higher than left dome, but in left L side, domes are situated in close apposition, red arrow, and left dome is high up. There should be marking for R for right lateral view and L for left lateral view. Q.22, what is the possible location of fissures in right lateral view? Right lung. At first we draw an imaginary yellow line from costo-phrenic angle over right lateral view. The line should connect the right hialum, then extend posteriorly up to vertebral column, dorsal 4-5 level. It is as like as oblique fissure. Then draw an imaginary transverse sky blue line which extends from anterior chest wall, pass through right hialum and reach posteriorly up to vertebral column. It is as like as transverse fissure. Q.23, what is the possible distribution of lobes in right lateral view? Right lung. Right upper lobe RUL, is situated anteriorly and directed upwards. Right lower lobe, RLL, is situated posteriorly and directed downwards. Middle lobe, ML, is situated between right upper lobe, RUL, and right lower lobe, RLL, and anteriorly. It is by the right side of the heart. Superior segment 6 is situated between right upper lobe, RUL, and right lower lobe, RLL, and posteriorly. Q.24, show the segments of right upper lobe in right lateral view CXR. Draw a pink Y in right upper lobe, RUL. It divides right upper lobe into 3 parts. One upper part of Y coincides with apical segment of right upper lobe. 2 posterior part of Y coincides with posterior segment of right upper lobe. 3 anterior part of Y coincide with anterior segment of right upper lobe. The segments of left upper lobe also can be shown by the above mentioned way. Q.25, show the segments of right lower lobe. Draw 2 lines parallel to a yellow line, right oblique fissure, in right lower lobe below B line, transverse fissure. Just behind the oblique pressure there is area 8 which represents anterior basal segment of right lower lobe, RLL. Behind the area 8 there is area 9 which represents lateral basal segment of RLL. Posteriorly over the vertebral column there is area 10 which represents posterior basal segment of RLL. Left lower lobe, LLL, can also be divided in same way. Q.25, continue? Area 7, that is medial basal segment, cannot be seen as the area is overlapped by area 8 and area 9. Area 6 is already described in Q.23 in previous slide, which is described as superior segment of RLL. Area 7, that is medial basal segment, is absent in left lung. Q.26, show the segments of middle lobe of right lung. Draw a vertical line from X point of BX line over the A line at Z point. Area 4, which is situated nearer to right hialum, represents medial segment of middle lobe, ML. Area 5, which is nearer to the chest wall, represents lateral segment of middle lobe. Q.27, what are the differences in distribution of lobes and segments in left lung from right one? In the left lung only oblique fissure is present. The AB oblique fissure, red line, cut at the point in left dome of diaphragm 5 cm behind the costo-phrenic angle and passes through left hilum and reach up to vertebral column posteriorly. Left upper lobe, LUL, is situated anteriorly and directed upwards. And left lower lobe, LLL, is situated posteriorly and directed downwards. Q.27, continue. There is no middle lobe in left lung. A part of upper lobe, which is situated by the side of heart, is called lingular lobe, LL. There is no transverse fissure in left lung. An imaginary CD green horizontal line is drawn through left hilum. Lingular lobe, LL, is situated between CD and AB line by the side of heart. Q.27, continue. An imaginary CE vertical line is drawn over AB oblique fissure. It divides the lingular lobe in two parts. They are designated as 4 and 5 area. Area 4, which is nearer to hilum, represents superior lingular lobe. Area 5, which nearer to chest wall, represent inferior lingular. Thank you all. End of ABC of X-ray chest Part 1. Learning Pulmonology.